name's Frank Johnson. I'm a sports medicine doctor up in Calgary, Alberta, Canada. That's where Mike and I met each other a long time ago, and we started teaching docs how to do ultrasound guided injections. I know, Mike, at the time you weren't doing much PRP. I think you're doing a lot more now, aren't you?
I've been doing, I would say, fairly steady PRP for about 15 years.
Okay. So Transcendent Biologics, who is hosting this webinar, thanks so much for hosting this. Thought we'd throw in a little theme of football. So I think that's a great way to start. But I want to introduce you to a couple of concepts. There's a 5-part protocol that I think you need to know to have success with PRP. And one of those is to draw a lot of platelets from your patients, because when you process PRP, it's quite common that you lose a lot. So meaning you spin the PRP, you draw it out, and you do not capture all the platelets. Some of them are lost in the red layer, some of them you just don't, they're kind of caught in the buffy coat or in the gel. So it's really hard to get everything. So grab as many as you can from the blood. Usually what that means is starting with 40, 50, 60 ml blood draw. So that's the first part. I would say the second part is select your patients very carefully. So patients that don't respond to anything, that, you know, are those heart sink patients, or patients with really, really high pain with activities of daily living, I would say those probably aren't your best patients to do PRP on. The patients that do great are younger patients, healthy patients, patients that respond, patients that have responded to PRP in the past. The third part of the protocol is do PRP at the right time. So what do I mean by that is, you know, if somebody just sprained their ankle 4 days ago, maybe PRP is maybe not the right time to do PRP. Maybe it's not even needed. Conversely, if somebody's got a rotator cuff injury and they've been rehabbing it for 6-8 months and not getting anywhere, we might have left that a little bit too late. Maybe you could have got to them a bit sooner. The other thing is with football, you don't want to make sure you're treating people at the right time of the season so that they don't have too much downtime or they don't suffer from their injury too much. So their team suffers. The next thing is, I'd say, prepare for the pain. PRP into body parts can be painful. Into joints isn't too bad, but tendons can be pretty painful. So I prepare patients that pain during injection and after injection is just par for the course. And the final bit, the fifth part, is to put the PRP, put the right amount of PRP in the right spot. Meaning, a tennis elbow obviously is going to take less PRP than a knee joint, for example. So how do we start with 10 billion platelets? So imagine if you've got, you know, Mike, what's the reference range for platelets in human blood? It's like 150.
Yeah, you know, I just saw a patient here right before I left clinic today. Her platelets are on the low end of normal, around 135 to 150. So 150 is like on the low end, and it can go up from there.
So if we imagine at a low end, you know, most people will have something like 200,000 platelets per microliter of blood. Well, what that means is 200,000 per microliter. You do the math, it's 0.2 billion per milliliter, 0.2 billion per milliliter. So if you draw 30 mils of whole blood from them, you're going to start the process with about 6 billion platelets. If you draw 50 mils, you're going to start with about 10 billion. So that's how you get a lot of blood. Selecting your patients carefully. This is a chart that I made in my clinic. We teach it in our courses. My patients love it. Every new patient I see that's an injection candidate, I give them a guided tour through it. I have them do a video of me giving a guided tour through it, because a lot of them will come to me having done a lot of these physical modalities and not wanting surgery. So I say, look, we could do cortisone. It's not healthy for the tissue. So there's this other thing. I'm in Canada. Docs in Canada, South America, Europe have hyaluronic acid for tendons. It's a low concentration. So I'll talk about that. Then we'll talk about tenotomy, prolotherapy, and PRP. So patients love this because they see it's sort of a menu. There's lots of different options, and they see this is your starter, this is your main, right? And not too many people go on to dessert, thankfully. And for joint and cartilage injuries, it's a similar sort of ladder. Prepare for the pain. This is how I prepare for pain. We're going to get into football cases later, but I want you to be aware that in my clinic, when I'm doing PRP for someone's tendon, I anticipate that they're going to have a moderate pain flare-up, and a lot of times I'll offer them codeine or T3s. If I think that it's really, really sensitive tissue, or they've shown me in the past they're really, really pain sensitive, I'll offer them Percocet. But that's personally me. What do you do for post-PRP pain that people get?
I think that what I probably offered the most is either tramadol or hydrocodone. Hydrocodone in Canada, Vicodin, you only know Vicodin because of House, right? So it's not available in Canada. But hydrocodone and tramadol are what I use most.
Gotcha. And I think not that many people need it, but it's nice to offer to them. At the very least, I think it signals to them this might get really bad. If it does get really bad, don't be afraid. That's just part of it.
And it might save you a phone call in the morning.
This is a sheet that I share with patients before the treatment, and these are all the things they need to do. We need to be aware of, and the rationale for this is over here. So when I was teaching things like, I want you to have a driver, they'll be like, well, why do I need a driver? Well, you might not need a driver if it's your left tennis elbow. But if it's your right tennis elbow and you drive a manual, or if it's your right Achilles tendon, you're definitely going to need a driver. So the other thing is people want to move. So I need to give them some advice. So movement is a stimulus for strengthening, but not too much. Immobilize the area for an hour, but then afterwards, no jarring or bouncing movement. So I'm not going to go in detail through this card, but there's all the advice I give them. And on the right-hand side is the rationale for why. Now, if anybody has any questions, put it into the chat, please. Happy to take your questions over the course of the webinar. I like sort of an interactive webinar, so please feel free. Type any questions in the chat. Do PRP at the right time. So how do we make sure we do PRP at the right time? Well, I wanted to take my boys to a football game, and this was me last Saturday at MetLife Stadium in New York. And how did I know MetLife Stadium in New York was the right time to take my boys to a football game? Number one, it was preseason, so I could afford 3 tickets. That's the first thing. The second thing, it was an evening game, which meant that we didn't have to suffer through 95-degree heat and humidity and sunshine. So that was the second thing. The third thing, it was New York Jets playing New York Giants. So no matter who won, one of the New York teams was going home as a winner. So that's how I knew it was the right time to take my boys to a football game. But how do you know it's the right time to do PRP for competitive athletes? So in season, I think if it's a big injury like a calf tear, a hamstring tear, they've done a meniscus or something like that, a big injury for tendons, I think you need to imagine that they might need to take 12 weeks off for a tendon. If it's a big injury, if it's a joint, at least 6 weeks off. Do you have any sort of rule of thumb when you're talking about big, and then medium injury and smaller injury, of course, smaller amount of times? How do you treat this? How do you treat your patients with this? How do you tell people how much time off, whether it's a football athlete or volleyball or tennis?
Well, I think that's a good point. I like how you break it down kind of into small, medium, and large injuries, because I think that's huge. And I try to share with them some data like, hey, with the average hamstring tear, that's maybe a small hamstring tear versus medium, I kind of share some information, what's normal return to play. And unfortunately, as we're doing PRP, we try not to rush it too much, but it's that balance, right? We want to get them back as soon as possible, but also as safely as possible, and want to give this PRP a chance to work.
Now, in season is very different than preseason. In season, you have a lot of negotiation. The more elite, the high up in their career the athlete is, obviously, the more you have to chat with the coaches. The younger they are, the more you got to chat with the parents about what the parents' goals are and what the kids' goals are. But preseason, at least I think just because it's preseason, a big injury is still a big injury. However, you have a little bit more time to treat them a couple of times. And same thing with off season. I think you have a lot more time to treat them more frequently. And this is, I had a guy one time who was sailing around the world, and he had recurring medial gastroc tears, and he was going to be in the Southern Ocean, and the leg from Australia to South Africa in the Southern Ocean takes 3 to 4 weeks. And so he didn't want to be in the Southern Ocean on a boat with 12 people where everybody has to pull their weight and injure his calf. So what we did was, about a year ahead of this boat race, we treated his calf 3-4 times with PRP. So that was an example of a big injury that had been recurrent in the off season, where we treated him 3 times. So luckily he gave me that much headway, and we were able to treat him effectively. So, there's a MetLife was huge. I've never been to a stadium that big. It was big, man. Put the right amount of PRP in the right spot. So I think there's a lot of people out there who feel really comfortable doing knee injections without ultrasound guidance and doing tennis elbow injections without ultrasound guidance. Absolutely. But I think with athletes who are paying for PRP, I think if in your community there are doctors that are using ultrasound and you're not, I think it's quite possible that they may not view you as the expert. They'll view the person who's using the ultrasound as an expert. Mike, you did your fellowship at Notre Dame. How much ultrasound training did you get in your fellowship?
Yeah, we did a lot. My fellowship was in 2009, 2010, and ultrasound was just starting to kind of pick up in the US at that time. And I was grateful. We had quite a bit of ultrasound training in my fellowship, and then we had a chance to go to some conferences at that time. And and I agree with this too. This having that ability to do ultrasound can separate you from some of your peers. But also, if someone's going to be spending hundreds of dollars on a really expensive product, you want to say with confidence that I'm giving this product to the right place.
So how do we know it's the right place? Well, so for rotator cuff tears, very frequently I'll place my needle tip right where the tear is, and they're not too bothered. But then I take my needle to the adjacent tendon. So for example, supraspinatus tendon tear. So let's say I've got a supraspinatus is torn on the bottom side, the deep side. A lot of times I'll put my needle here and it's not sore. I'll put my needle up here and they're exquisitely sore. Or I'll go to the adjacent infraspinatus tendon that's totally intact and I'll touch that and they hit the roof. So that's one of the other things with ultrasound is you can identify where's the injury, but then also when you find that pain spot, you can document where that really, really painful spot is. So when you go back to treat them next time, you can make sure you evaluate it. Hey, is your infraspinatus as sore as it was last time? No, hey, that's a great sign. So we have an online PRP course at Sports Medicine Ultrasound where in my clinic, I've set up a video camera, microphone, and I show you what you should be seeing on the screen. I do annotations. You can see down here for this ankle, I draw on the screen where you should be placing your needle, where the PRP needs to land. So you really know what you should be seeing on the screen. I remember when I was learning ultrasound, I was about 4 months into this course I was doing, and I emailed my tutor and said, do you have a video of you doing a subacromial bursa cortisone injection? Because I just want to make sure I'm doing it right. And he didn't have it. He wasn't in the habit of doing video in his clinic. So he said, Frank, I've seen you scan. I saw you in Cadaver Lab months ago. I'm sure you're putting it in the right spot. And while that was a compliment, it wasn't reassuring to me at that point in my career. It didn't answer the question. It didn't help guide me. So I thought, you know what, I'm just going to record a bunch of videos, and you can Google this stuff. You can go on YouTube. However, this library I've put together actually a library of over 100 different types of injections, and I think it can really, really help you. So I won't go too much through this. Let's get right into some papers. So in preparation for this talk, what I did was I Googled, I looked for a whole bunch of papers what did I search? I searched PRP NFL, PRP NBA, PRP college sports, PRP, a whole bunch of other things. I found some papers. So one of the ones that I want to mention first was a British Journal of Sports Medicine paper published in 2023 by Shane Shapiro. Shane's at the Mayo Clinic in Jacksonville. He is sort of head of their orthobiologics division, their sports medicine division. So he does bone marrow, he does adipose, he does PRP. And he and 3 of his colleagues, including Ken Mountner at Emory, put together this nice graphic. So essentially what it says is, you've got this magic cell, whether it's a stem cell or a platelet, and he wants to suggest that you put together a tiered approach. So what's that look like? Well, you want to look at what's the best available evidence for the body part or the injury in question. So let's specifically talk about, an Achilles tendon injury, a small injury to the Achilles tendon. What's the best available scientific evidence? How good am I? What's my expertise with treating this injury in this type of athlete? And then what's the patient's values and preferences? So those are 3 things to consider. And then on the right side of this graph, he says, well, what what level of evidence, meta-analyses, randomized controlled trials, case series, case report, or anecdotes is there available for specifically this this low-grade Achilles injury? So there's a question from I just look over here at the Q&A, and so I'll answer this now. Quad tendon pain during the season. How do I treat this? Let me go back to that how do I treat that before I continue on with this. So Mike, how do you treat quad tendon pain? And again, specifically, I'm assuming we're talking about moderate pain that is not disqualifying someone from sport. Actually, before we go on, Mike, I think I wanted to ask you ahead of time. How do you specifically disqualify someone from sport? And let's use this quad tendon pain as an example.
Man, that's like a loaded question. I think a lot of it is depending on kind of what's their pain, what's their function, what's the imaging show, what's their position. I think there's a lot of factors, and can they contribute with their injury at that time? So you can imagine if I have someone that has a pretty serious injury and I'm concerned if they return to sport, return back to football, and it's actually going to cause further damage, okay, that's a no-brainer, regardless if they're the starting quarterback or not. If I have someone that has maybe a low-grade strain and they're the fifth string safety, we have some time, right? And we really try to utilize the athletic training staff. And but we utilize all the imaging and make sure we get a really comprehensive picture. So I'll just start with that. So yeah, there's a lot of factors, a lot of variables for sure.
So specifically with PRP, I would say my threshold to do PRP on an in-season football player, let's say, is pretty high, simply because as soon as I stick PRP into someone's quads tendon, I'm going to anticipate that they're going to get increased pain for 2 to 3 days. Their quads muscle is going to suffer from pain inhibition, and it's not going to function appropriately for probably 6 days after that. So they're actually at an increased injury risk specifically because of the treatment that I did. So I would say if I do PRP, they're out from scrimmage and games for at least a week. I'll probably get them on the bike at day 2. But yeah, these are great questions. And I think having these conversations with as you say, the athletic training staff and the coaching staff is super important.
I'll throw in one other caveat. I think you bring a good point too, Frank. Load-bearing tendons, so like quad tendon, patellar tendon, Achilles tendon, plantar fascia, sometimes those can be a little bit more difficult in season 2 because you are bearing load when you have an explosive athlete in football.
Gotcha. So yeah, please feel free to put the questions in there as they come up to your mind. Okay, so the Shane Shapiro article says here, look, there's different tiers of evidence. Tier 1 is high quality evidence for that specific body part. 2 is not so great, and 3 is not super robust. Or let's say there's prohibited status. So let's say, for example, Wharton's jelly in the United States or amniotic tissue in the United States. So essentially what he says is respect to currently used orthobiologics, not just PRP. There's certain things that are that fit the tier 1 proven safety with robust evidence. And I'm not going to go too much into it, but it essentially says in the final one here was, tier 1 evidence. He says that, for example, such as Achilles tendinopathy and ankle arthritis don't have as good evidence as some other things. He shows that certain tendinopathies, for example, rotator cuff and lateral epicondyle, demonstrate strong safety and reasonable efficacy. So I think this Shapiro one is at least a good one to go to for you to type up something into ChatGPT, so you can type it at you can use these in your office about what you think, excellent doctors in this field, where they think some good evidence lies. Tier 2 would be proven safety. However, there is growing evidence. Tier 3, again, less evidence, and maybe some regulatory stuff. So, to be clear, I am not an expert in the regulatory realm in orthobiologics in the United States, but as an example, perinatal injectables, umbilical cord, Wharton's jelly, amniotic tissues at the moment are currently completely no-go in the United States. As per the FDA, that may change in the coming years. However, it's essentially a no-go. There are some movement at state levels. I think Utah, I think Florida are moving to change some of these things, but if patients ask you about those, they're essentially no-go. It's not worth risking your license for something that falls into this tier 3. In fact, in some cases, actually going to jail. So it's just a no-go. That's why we like PRP. So I think, yeah, and then this shared decision-making is the next step. And that's where we talked with Mike about in season. Are we talking starting quarterback? Are we talking tier 5 or, 5th string cornerback? So paper 2, I'm just going to leave this on here to think about what's the best available evidence, clinical expertise, and patient values and preferences. So I've got 4 other papers that I'm going to demonstrate here that are published based on surveys, because I think surveying your peers or surveying orthopedic surgeons, surveying experts in the field is certainly not a bad way to go. It's not as good as randomized controlled trials, but it's good to know what other people are doing. And so this was a paper that surveyed 599, don't know why they couldn't come up with the 600, but 599 members of the American Orthopedic Society for Sports Medicine. So these are surgeons, specifically about, and this was a paper published in 2021, and it asked them about all these different things. So, and they asked about osteoarthritis, muscle injuries, tendon injuries, ligament, labrum, and focal articular cartilage tears. 165 responded, so about a quarter of them responded, and almost 72% are increasing the use. So 66% using at least one orthobiologic, almost everybody that's going to be PRP. 71% are increasing their use, 24% advertise their use. PRP was the most common at 76%. And a lot of them said they're doing it because their competitors are doing it. There is some of the keeping up with the Joneses. Mike, in your community in Tyler, how many docs do you think are advertising PRP? Are you advertising PRP?
Yeah. Ooh, so actively advertising it? I guess, what do you mean by advertising? I'm thinking, so I'm in a community of about 100,000 people, but we service a pretty large area. During the day, it probably population's up to around 300,000 people. Probably have around 25 orthopedic surgeons. We have about maybe 6 primary care sports medicine docs. Out of those 6 primary care sports medicine docs, I think 4 do PRP, and their institutions mention it, but they don't actively promote it. But it is something that is kind of, I would say it's probably more promoted within the organization versus promoting to the public itself.
So I heard you say out of the 6 primary care sports medicine doctors in your community, probably 4 are doing it.
Mm-hmm.
Well, that's interesting. That almost lands bang on with this 66% shown in that second line. That's interesting. Yeah, you are average, Mike.
It's good to be average.
The second thing was I didn't know these existed. I didn't know these position statements existed. Now this was 2020. Now when I saw this timing of this NBA orthobiologics consensus statement, again, I know we're supposed to talk about football today, but I thought this was interesting. This smells of a make work project during COVID to me. It was published in 2021 and it was a 2020 consensus statement. But essentially what they did, it's nice to see. And now I bet these numbers are higher. I bet the consensus statement, if they were to redo it now, they'd show more docs doing PRP and more body parts. Now there may be a few body parts where they say, for example, Achilles tendon, back in 2020, they said they do not recommend the use of orthobiologics injections for Achilles tendinopathy at this time. This is an interesting one, plantar fasciopathy. They recommend as an adjunct to first-line conservative treatments and or when conservative measures fail. I don't usually consider PRP as an adjunct to first line, but I think that's interesting that these docs who answered this survey for the NBA said, no, we do. Next thing was a paper this was 2018. And what they did was interesting. They sent out surveys to 149 professional and collegiate team physicians covering NFL, NBA, MLB, NHL, Major League Soccer, and the Power 5 D1. 59 of those started the survey, 46 completed. So that's, 40% completion, 30% of them completed it. And essentially they said professional and collegiate teams frequently use PRP despite a lack of consensus regarding the importance of the formulation of the product, meaning they're using it, but they didn't necessarily say, yeah, we're all using the exact same process to make the PRP or the same recipe. We're not all using the same timing of the treatment, and we're not all using the same, not all treating the same conditions. So this goes back to the what's the best available evidence and what's your clinical expertise in it. So maybe obviously a soccer doctor is going to get a ton of hamstring and they're going to get a ton of groin injuries, not so many rotator cuffs or shoulder labrum injuries. What they found was that 93% of the docs who responded says they use PRP in their practices, and 72% use ultrasound injection. Interestingly, they found that in the NHL, they found the fewest were getting injured, and NFL were highest. Now, I don't think that's a surprise. You know, in talking with the doctors who take care of our local football team, like their injury list is off the charts compared to our guys that take care of the NHL teams. Would you agree, Mike? You see a lot more injuries in football than in hockey?
Yeah, and I think it's just, you know, obviously the nature of the sport. Hockey is with that gliding motion, you're going to see different injuries, generally speaking, than football, at least the severity. You'll definitely see your share of concussions for sure, though.
Oh, absolutely. And interestingly, so a lot of the NFL, this was 2018. A lot of the NFL guys were treated for hamstring injuries. So I thought this was interesting. I'm going to come back to this. What they found was that those who were treated with PRP missed on average 1.3 games. The ones who did not receive PRP missed on average 3 games. Now in the NFL, that is money. That is, now obviously we don't know the specifics. Maybe they only chose to treat people with lower grade injuries where they weren't, they were probably going to do fine anyway, but hey, why don't we use a little bit of PRP? So it's hard to read a ton into that, but I thought that was interesting. I personally have treated very few hamstring tears with PRP. Can you think of any that you've treated with PRP, Mike?
Yeah, I think similar to you, not many, not many. It's not a common area to do PRP on, but a handful.
But there's some, I'm not going to be able to pull up this study in my mind here, but there was a paper done in Spain by a guy named Carlos Pedret, and Carlos and his team looked at hamstring injuries in elite soccer in either Spain or in a couple of countries across Europe, I can't remember, and they did see a reduction in time away from sport with PRP. So it was a reasonable thing to offer people. So that was a 2018 paper, and then this one came out in 2020, and it was a paper that actually looked at this practice. So it might have been something that was talked about in conferences, and somebody said, we should actually do a paper on this and actually see who's getting treated and how well they're doing. So this was an interesting one. And what they found, they looked at 108 NFL players who had MRI evidence of a hamstring injury. 69 of them sustained grade 2 injuries. 30 players received PRP treatment, and 39 had non-operative treatment alone. So now how many treatments did they get? They saw that, physicians stated that they moderately believed in the evidence behind PRP. That's okay. That's sitting on the fence. That's fine. Hamstrings are the most common, and they found that they wound up treating them 3 times for hamstrings and 2 times for non-hamstrings. So just a reminder that there is no magic bullet. PRP is not a magic bullet, and treating injuries with PRP one time is not necessarily an adequate dose of PRP. So, and then number 6 was use of biologics in NFL athletes, an expert consensus of NFL team physicians. This was published in 2023. And what they did was they NFL London. I didn't know NFL London was a thing, but that's okay. 47 statements reached consensus, which is pretty impressive. And essentially what they came up with was, oh, I think I might have gotten some of these. Whoops, forgive me. I think I got some of those messed up when I was doing the slides earlier today. But what they found was that a consensus was achieved that PRP had a positive impact on patellar tendinopathy and on symptoms in early arthritis, but not a lot for other conditions. So if you do want to do some more research there, there's some good papers there. NFL consensus statement, and an NBA consensus statement from 2020, NFL paper on hamstrings, and then the Shapiro one talking. And this, I think this one's very practical. What's the best available evidence? What's your clinical expertise in the area? And what's the patient want? And then what's the level of evidence for that for your specific body part? So for football, most of the shoulder issues I see in football players are tendinopathy, not rotator cuff tears. They're mostly tendinopathy, they're biceps tendon pain, they're AC joint injuries, and they're suspected or proven labrum tears. Would you agree with that, Mike? Tendinopathy, AC joint, long head biceps pain, and suspected or proven labrum tears.
Yeah, I think everything you said, and the other thing that comes to mind is some AC injuries, AC joint injuries as well, sprains, subluxations, yeah.
For sure. So how much PRP do we put in them? Well, I want you to prepare for supraspinatus tendon pains. I want you to prepare a maximum of 6 milliliters of PRP. Now, if you've treated this person before and you know that their tendon is robust and solid and you can't put in any more than 2, sure, next time don't grab 6. But there's some tendons that are really sort of forgiving, and you can put a lot of PRP in. And again, if I suspect somebody has supraspinatus tendon pain or a small tear, and I put my needle into the supraspinatus right where the tear is, and they don't have pain there, I will also eject the adjacent infraspinatus, usually long-headed biceps, and sometimes subscapularis. The concept is get a comprehensive treatment around the injury. So rather than just, so imagine we had a hamstring tear, and the hamstring tear was a certain area, and you only treated that certain area. You're missing all the area adjacent it that might be prone to future tearing. So that's why I really want to get a really good comprehensive treatment all around the area. However, 3 milliliters for supraspinatus and the adjacent areas is a reasonable amount, but first several times you do this, I want you to prepare about 6. On this graph here, on this image, is the top left panel is a zoomed in image on a skeleton where we see the acromion here. That corresponds to the acromion in this ultrasound image in the bottom left panel. Here's the humerus with the curve here flattening out to the supraspinatus attachment. That corresponds to this curve flattening out to the supraspinatus attachment. Over here, we have an injured supraspinatus tendon. Here, all the fibers are good. Here, we see a gap in the tendon. Here, we see an area where the tendon's actually pulled away from the bone. Here, we see an irregularity in the bone. And then here, we see actually a dip in the bursa. When you see a little dip in the bursa, this is one of your indirect signs of a tear. So this is a pretty high-grade tear of the supraspinatus. And how do I treat it? Well, again, I put my needle here, inject a bit there. I put my needle here, inject there, inject here, and then I fill up this entire area. Invariably, the fluid will also flow outwards into the bursa. Now, Mike, some of the docs that I teach with have seen patients with pretty impressive post-PRP to the rotator cuff inflammation and pain. Have you seen that?
Yes, shoulder can be tough. I've been there, so personally, yeah, it can be tender and painful afterwards.
Oh, tell me about. I can't remember this story. Tell me your PRP for your rotator cuff story.
So this is way back in the day. I had PRP and prolotherapy many years ago, before actually I had cuff surgery and labral surgery. But I trained with the doc. He did a lot of prolotherapy and was getting into PRP. And I saw some of these patients, they were pretty sore afterwards. And I thought, it can't be that bad. And during the procedure, I was tender. He was lidocaine. It was tender, but that night, oh my goodness, after that lidocaine wore off, like my shoulder was on fire. And for probably about 3 days, I was so stiff and achy in my shoulder. I thought, what have I got myself into? But yeah, I gained kind of firsthand appreciation of like a post-injection inflammatory flare.
So personally, do you think the PRP was helpful for your cuff injury?
I actually had, so I'll say yes to a point. I had a partial supraspinatus tear and a labral tear. What's interesting is I found my pain got better, but I continued to have instability from my labral tear. So I eventually had surgery to improve a lot of my instability. But it's interesting, yeah, my pain actually did improve though.
Good. At what point did you notice it improve at the 1 month mark, the 2 month mark?
I would say it was probably around 2 to 3. And honestly, I had some prolotherapy with that. So I had some subsequent prolotherapy treatments in addition. And I had a total of 5 prolotherapy treatments. But it was, I think, after the second treatment that I started. So, after 2 months, I started noticing improvement.
So for those of you who aren't familiar with prolotherapy is one of those treatments that, 10, 20 years ago, 30 years ago was pretty,
taboo.
There wasn't as much Instagram, the internet, wasn't as big. It was hard to find evidence. And so not many people had heard about it. Of course, when you hear about things as a doctor, when patients tell you about things you've never heard of, we're most likely to dismiss them. But I certainly trained as a prolotherapist and found cases where it helped and a lot of cases where it didn't. How do you use, so prolotherapy is essentially repeated needling of an injured tissue, whether it's a ligament or tendon, with lidocaine and dextrose. And it fits along a spectrum. So I think dry needling with physical therapy is the sort of least intrusive version of it. Needling with lidocaine, so putting in lidocaine first and then repeated needling, which a lot of times we call tenotomy or fenestration, is sort of the next step up on that spectrum. Repeated needling with lidocaine and dextrose is next on the spectrum, and then repeated needling with blood or concentrated plasma is next along the spectrum. Do you see it along the spectrum, or do you see them differently, Mike?
Yeah, definitely. I agree 100% with what you just said.
Now, are you in the habit of treating patients with PRP and prolotherapy for rotator cuff injuries, or does it go back to that Shane Shapiro sort of, patient values and what they think is important and what's the evidence? How's it go?
Well, now, I have to say that I have to value the patient now that you said that. But generally speaking, I chat with them about prolotherapy and PRP. I honestly find PRP, generally speaking, is stronger and a little more effective than prolotherapy. But the downside with PRP, you were saying you're given a finite volume. Let's say you're given 6 mLs of your solution, your PRP. I can only target so many areas along the shoulder. And so I will often use prolotherapy to augment, because I do agree. Let's say, man, I think that infraspinatus, even though on MRI it looks normal, clinically they have some tenderness, maybe a little weakness and dysfunction. I think it is appropriate to target those surrounding structures. And that's where I'll often augment a PRP treatment with that dextrose prolotherapy.
Gotcha. Thanks. So here's an example. I'll show you how I do rotator cuff. Now, what we see here is this is a syringe with normal saline. So it's a 10 milliliter syringe with normal saline. I add 1 milliliter of lidocaine 1% to essentially a full syringe of normal saline. So I take my lidocaine from 1%, which has been shown in a petri dish to be cytotoxic to platelets and to stem cells, and I dilute it down to 0.1. Now the reason is I'm not treating someone in a petri dish. I'm treating someone who has pain. And Mike, you said yourself you had anesthetic into your rotator cuff, and so you tolerated pretty well. But then when lidocaine wore off, I was pretty sore.
Yeah.
Are you in the habit of using no lidocaine for rotator cuff and other body parts? So no lidocaine, dilute lidocaine in small amounts, so no lidocaine, small amounts of lidocaine and or dilute, or a ton of lidocaine to make it comfortable.
Okay, I'm going to split the difference. I used to use a lot of lidocaine, just bathe the area, do a lot, even intratendinous, make it as comfortable as possible. Maybe that was me being a little jaded from my experience. But I think as we've had more experience about and more evidence about the lidocaine potentially inhibiting platelet function, I now try to use the least amount of lidocaine that I can get away with, both in a tendon and in a joint.
So if anybody has any questions about lidocaine, please put it in the chat, because I know there's literature out there. I think the best evidence that I've seen for platelets and for stem cells is, and when I say stem cells, I mean bone marrow aspirate or adipose concentrate, is ropivacaine. Doesn't seem to be cytotoxic, but some people say, I just don't want to keep ropivacaine in my office. I just don't use it enough. So for whatever that's worth. So the video here is part of the online PRP course. So you can watch that in your own leisure. So all you got to do is go to, I'll put it in the chat later, sportsmedus.com, and you go to online, and you can see our free PRP course. And then this entire recipe book is available in the paid course. So long-headed biceps, just small amounts, 2 mils is a common amount for long-headed biceps. Long-headed biceps is very frequently painful or tender, at least with needling. AC joints, a lot of times what I'll do is I'll use, one of the concepts with prolotherapy and PRP is that it can help strengthen up tissues to a degree. So for example, if somebody has a grade 3 with elevation, grade 3 separation of their AC joint with elevation of the clavicle and widening, there's no liquid product you can put in there to bring those back into congruence. However, if the patient isn't going for surgery and we're trying to get any increased stability we can along with pain reduction, then what I do is I put about 3 milliliters into the ligaments above the joint, anterior to the joint, posterior to the joint, and also at the deep aspect of the joint by coming from the front, and then about 1.5 milliliters total into the joint. Do you have any secret weapon when it comes to AC joint injuries? Grade 1 or grade 2 sprains?
Yeah, I do find the more severe the injury, similar to the other areas you can extrapolate, then the less optimistic I am that PRP is going to do its work. So, I mean, if I have someone with like a chronically painful grade 2, I'm usually really optimistic I can control their pain and improve their function with PRP. Grade 3, it's a little bit challenging. I probably need larger volume and repeat treatments. But I like your approach. You're not just going just into the joint. You're kind of doing this comprehensive treatment of those ligaments. And I'll even add that coracoclavicular and coracoacromial. I'm trying to really target those as best as I can as well with my PRP solution.
Gotcha. So glenohumeral joint, the one we think about most frequently is labrum tears. Now, I think there's an epidemic of labrum tears in the hip and in the shoulder. And I think what's causing that epidemic is a readily available 3 Tesla high resolution MRIs, meaning somebody injures their shoulder. Yeah, it's quite possible they injured their labrum, and then they get a picture and it shows a small labrum injury. Well, of course, we knew that. We've always known that. We've known that for decades. But now we can see it. So the trick with labrum tears is to put them into context. And Mike, you were talking earlier about your experience. You were having sort of repeated sort of instability sensations with your labrum tears, so you went on to have a surgery. But are you concerned, or how do you handle that? Somebody comes in with an MRI showing a small, non-displaced labrum tear.
Mm. Well, I think that's good differentiating too. So I mean, you're looking at the size and the location of the labral tear, and are they having like mechanical catching symptoms? I think I'm going to treat them differently. I'm more likely to go towards surgery. If there's a small labral tear and there's some other pathology I think that may be amenable to PRP, I say, hey, totally reasonable to try that.
Now, the other thing is I do see a lot of people who've previously had labrum surgery and they're coming back to me with ongoing symptoms. There's no treatment that I'm aware of for anything in medicine that's universally effective. So just be aware that although Mike and I are kind of saying, hey, you got mechanical symptoms and, instability, talk about surgery, that doesn't guarantee the patient's going to have a satisfactory outcome. It's going to go great. So absolutely, I think it's reasonable to offer them PRP, or if they ask about it, talk about it as an option for sure. For glenohumeral joint for labrum injuries, I like to keep it simple. People that take my courses are usually earlier in their career developing their own expertise, and all we want to do is get it reliably and consistently into the glenohumeral joint cavity. There are some courses out there that say, oh no, you really want to get it right into the labrum tear itself by going through a certain approach or whatever. And I think that's absolutely great. However, most of the folks who come to my courses are sort of at the earlier part of their career, and I don't think you're under treating someone by just getting it into the glenohumeral joint. What are your thoughts, Mike?
No, I agree. Yeah, very much so. And sometimes it's really difficult to target some of those anterior superior labral tears under guidance. It's just really hard to approach. So I think just going intra-articular is a great approach.
Now, the other thing here is we want to remember now this goes for meniscus tears in the knee, labrum injuries in the hip, labrum injuries in the shoulder. The labrum is not a discrete absorptive chamber, meaning it's not like we've got to get to exactly the spot where the tear is with the needle tip. The labrum is cartilage, just like your nose, and it's rubbery, and your plasma is a watery substance. So if you take cartilage, imagine like cartilage from a chicken breast or something. If you shoot water at it, it's going to bounce off it because the cartilage is like rubber. And if you take a needle and imagine sticking it into cartilage and trying to push water into cartilage, it just doesn't go easily. So the point there is, even those docs that strongly advise putting your needle tip exactly where the cartilage injury is, I would still love to see high quality evidence to suggest that, number one, the PRP stays there, and number two, it gives better outcomes than simply putting it in the joint. I'm not saying it doesn't. I'm just saying I just haven't seen the evidence yet. So that's another way of saying if you just keep it simple, you're probably doing the right thing.
Yeah, I agree 100%.
So this is a gentleman where for his shoulder arthritis and his degenerative labrum injury went posterior to anterior, and my needle lands there. I won't play the whole video, but I'll just fast forward. Again, these are the videos that are available in my 100 injection video library, but also the PRP course online. And essentially, I'm just getting my needle tip through the deltoid, down to the infraspinatus tendon, and touching the cartilage of the humerus, and the fluid flows into the glenohumeral joint cavity itself. Common extensor tendon, I have a few law enforcement officers who have really, really stubborn common extensor tendon pain. And one of them recently, this ladder, this spectrum of approach with needling, I simply did I wanted to gauge how sensitive this common extensor tendon was going to be to PRP. So how did I start? Well, I didn't start with PRP. I started with simply lidocaine and needling. And his pain with lidocaine and needling went up for 0.7 mils of lidocaine into the tendon, and maybe 15 passes with a 30 gauge 1-inch needle. So pretty low dose. Pretty small treatment, but his pain went up for 3 or 4 days and lingered for about a week and a half. So that was one of those ones where I said, I'm glad I developed a rapport with this patient before I put in the PRP and sent his pain probably off the charts. Are you dabbling with that at all, Mike, where you do a test injection just to see, just to feel out the patient's tissue a bit?
I haven't really done that much. I would say I've done like a lidocaine test just to help confirm my diagnosis, but not necessarily kind of with that titration of the algorithm. I often will start, now depending on a lot of factors, but many times I'll start with cortisone. And then if they're failing cortisone, then we have a whole lot of other treatments like rehab, physical therapy, etc. And then we get back to injections again. I'm usually talking about prolotherapy or PRP at that stage.
Gotcha. So common extensor tendon, I'll get 4 mils available. 2 to 2.5 milliliters is a common amount. I want to make sure I'm getting, so I tend to inject these. So I started in long axis, so my needle's coming this way. getting to a certain spot, and then I'll turn my probe in short axis, and what the tendon looks like is an oval. And once it's an oval, I'll then take my, here I got a stylus. I got a stylus here from my tablet. I'll put the needle there, and then I'll make sure I touch a whole bunch of different spots in the tendon, both the common extensor tendon. Then sometimes I'll actually move a bit more proximally up to the extensor carpi radialis longus, a bit higher up on. But then I'll also go into the muscle belly a little bit further down, because a lot of people have tennis elbow pain that's sort of, here, not just at the tendon. Now, there's also a lot of new papers coming out about posterior interosseous nerve pain. I think that, focusing on that runs the risk of us missing the fact that this is most likely a tendinopathy. What are your thoughts on that, Mike?
Yeah, I tend to think of that as a diagnosis of exclusion, like they're just not bouncing back from treatment as expected. Then they start chasing some of those branches of the radial nerve to look for entrapment. In fact, believe it or not, my very first patient tomorrow morning is suspected kind of pin syndrome. So
good luck.
Yeah, I know. I was like, oh, those are tough. Those are hard.
Tears in the common extensor tendon. So what we see on the left here is a normal common extensor tendon and radial-collateral ligament. So just for the sonoanatomy here, the top half, essentially the top half of this part here is tendon. The bottom half is what connects bone to bone. Well, what connects bone to bone is ligament. So the bottom half of the image is essentially ligament. So here we see bone. This is the radial head. This is cartilage. And then this is ligament tissue. So if we're to follow this ligament tissue over to the right, we see an interruption in ligament tissue. So this is actually a ligament tear, and we can see sort of the ligament tear. It's not truly retracted like a tendon pulled away, but you could, in a sense, call it sort of retracted ligament tear, but it's not like a ruptured Achilles with retraction or supraspinatus with retraction. This I would call tennis elbow due to a ligament tear. And then I would put my needle here, and if they had absolutely no pain here, I'd say, I think your tendon's okay. And I would continue sort of touching the needle around here, trying to see if the pain's in the tendon. And again, that's just trying to figure out where's the right spot. I would then migrate my needle down to this spot, and if they hit the roof, I'll be like, oh, okay, your pain's more sort of where the tendon's torn. Are you doing that same thing, Mike? I was talking about that with supraspinatus, but here's a nice visual example where there's an injury here. But I want to be clear, if you put your needle right here and only right there, that's fluid. The patient, there's no nerve endings in fluid. So it's impossible for your patient's pain to be coming from right there. It has to be coming from something adjacent to it that's still intact.
I used to always focus on like treat the defect, treat the hole. And with time, I'm really trying to treat the adjacent injured tissue. And I'll try to obviously dump some of that PRP into that hole as well. But yes, I'm trying to do like a broad treatment around that injury, because that's where a lot of the injured painful tissue's at.
Gotcha. So I think we've gone through a bunch of the concepts. We're coming up on time here. This conversation went really quick. This is great. Again, any more questions, feel free to put them in the chat. Common flexor tendon, once again, smaller amount than common extensor tendon. Elbow joint, 4 mils, CMC joint. I treat a reasonable number of collision athletes or combat athletes with wrist pains and pains on the back of their wrist. So I think that's definitely a reasonable thing to treat with PRP. I think that hip joints, we didn't get, it feels like we need a 2-part lecture, one on upper body, one on lower body. But hip joints, I think that there are a lot of hips out there you can treat with PRP, because I do not want to be putting cortisone into young athletic hips. Do you have any thoughts on that, Mike?
Yeah, I agree with that. I find hips are challenging to treat even with PRP. I don't find they seem to respond as well. But if I have a young athlete, especially a high-level athlete, I'm cautious to dump cortisone in that too.
Sports hernias, I see a lot of this, almost exclusively in men. I got one female hockey goalie right now with sort of adductor longus pain, but both she and I think it's probably more the hip joint is the main epicenter of her pain. So sports hernias, you treat the adductor longus, you treat the pubic symphysis and the anterior pubic plate where the adductor longus and the rectus abdominis meet. It's super tender in males. You have to be able to learn how to find spermatocord and stay away from that safely. Obviously in women, not near as much of an issue. SI joints, I don't treat SI joints in athletes with PRP as much as I do prolo. What would you say? I think I do more dextrose prolotherapy than PRP.
So same for me, and part of it is volume too. If I'm only given a limited number of 6 mLs of PRP, I can use 20 mLs of dextrose and do a pretty comprehensive treatment of bilateral SI joints.
Included in the PRP premium course, you get to see the bums of one of the doctors I worked with who needed an SI joint treatment and consented to this video being taken.
I'm so glad I don't work with you, Frank.
Knee joint, of course, is the one that we always think about with PRP. I used to inject not as much. I used to inject sort of 5 or 6 mils max, but the knee can take a lot of fluid. I think 8 mils, I'm doing a lot more 8 mil and 10 mil injections because I want to get as many platelets in there as I can. I am all over that with PRP. That's one of my biases. I think that is something that responds well to PRP. I also think it's something that can be quite painful, but I think it does respond to PRP. For quadriceps tendon, patellar tendon, these ones tend to be chronic, meaning like they come back over and over season after season after season. So I think you've got a lot of time to work with these patients. And I don't think PRP one time is going to cure them. You have any thoughts?
Yeah, that makes me think maybe 2 stories. My nephew is a stud basketball player in high school, and he had proximal patellar tendinopathy, had PRP actually by Frank, and his had been stubborn, and I think he had multiple treatments, couple treatments from what I recall.
I think I did 2 for him.
Yeah, and he did have improvement, but I mean, I think that really just points like, boy, these can be hard. It was interesting. I just had a runner recently, and she had anterior knee pain, diagnosed with proximal patellar tendinopathy for probably 18 to 24 months, had a lot of different treatments, had not had PRP in the past. And so it came to me specifically for PRP. We did 1 treatment. She came back and saw me 6 to 8 weeks later. And she's like, I'm 90% better. And I'm like, I don't know if I buy that. Just because they usually are stubborn. They usually need multiple treatments and they usually take longer. But yeah, and then I've seen her one more time since then, just kind of follow up. And so she's, I think, about 4 months out from her PRP with her 1 treatment. And she actually did really well. She's doing great. She's not limited in the gym right now.
Ankle joints. I don't treat a ton of ankle joints with PRP, but we run courses for podiatrists. One of our podiatry lecturers is a podiatrist at the Mayo Clinic in Rochester. She's like, oh, I use PRP for ankles all the time. I'm like, of course you do. Your ankle is my knee, Yeah. She's really happy with the results. She offers it to most patients. So I think it can be really helpful. And where does it go? Well, of course, it goes in the anterior recess. Well, you can access the ankle joint a couple different ways, but in our courses, we say, look, just put it sort of anterior and distal to the medial malleolus into the fluid on the anterior anteromedial talus and fill up that space. And ankle ligaments, I treat ankle ligaments a ton with PRP simply because these things are ubiquitously injured and a lot of people have ongoing pain. They come to me hoping for increased stability. I don't think it's that great at offering increased stability. You need reflexes of a cat and training and physio, and the PRP can help. What are your thoughts?
Yeah, I do find that there can be some improvement in stability, but exactly what you said, I find it takes a while, and it's really like this multidisciplinary approach. It's not just like PRP in a vacuum. I'm going to do 1 or 2 treatments and you'll get it back. They really have to do a lot of proprioceptive treatment and like really good rehab, I find. And then not only their pain improves, they should have improved stability too.
Excellent. And plantar fascia, well, we know from the NBA, it's that NBA consensus statement, which would surprise me. It said they offer it as an adjunct to first-line treatment. I don't know if I'd want that put in my plantar fascia as first-line treatment, but I'm assuming they deal with this a ton, and they're like, man, there's not a bunch of other good treatments that work for our athletes, so they're starting to offer it. So and here's one of my police officers who I did actually. This was a hyaluronic acid product. But he was pretty sensitive. So just know that, man, sticking a needle in somebody's heel, it can be sensitive. As you see, he's not liking it that much. So we've got, as I say, we've got courses to help you learn how to do PRP. We've got free courses. I'm going to go to that now, sportsmedus.com, and go to online and go to PRP courses and start the free PRP course right there. We've got a premium version with all the videos. If you're also interested in a video library, we've got a video library. It's $149 and it's about 6 hours of injections. These are injections that I've done in my clinics with patients that have consented to me doing the video, that after the fact, I have taken them to my video editing suite, which is right here, and annotated them and done picture-in-picture. So I don't think there's any better videos on the internet. You can Google stuff and check YouTube, but this is my business. This is my passion, making good, high-quality educational videos. So I think you can't go wrong with this product. So with that, I'm thinking I'm going to pass it back to Craig. We're at 7:06. We've gone over time just a tiny bit. I hope that was helpful to everybody. We had maybe about 60 people register, so I think they're all going to be eagerly watching this in their inbox tomorrow, because I think a lot of people are probably out enjoying the summer sunshine while it still shines.
Sure. Awesome. Hey, thank you guys. Really appreciate it. Hey, to everyone that's joined us tonight, we are giving you a 20% discount on PRP, and we do have high volume PRP. We go up to 88 ml blood draw, 66, 44, 22, and 11 are our kits that we have. And so we can meet everybody's need. And we also will give you a free centrifuge as well with the order. So if you're interested, just comment to us, give us a link, give us a call, and we greatly appreciate everybody tonight.
Excellent. Mike, thanks for your help. Craig, thanks for hosting, and we'll see you next time.
Thanks, guys. Appreciate it.
Have a great night. We'll see you later.